But it's week 4, it's Thursday. This is part 1 of a 2-part lecture series here on the long Thursday. Alright, so we just got done with the esophagus. We got into the stomach. We talked about the stomach last time. It has different regions, right? And it's pathologists. This is pathology, GI pathology, so we use the histological and pathological divisions of the stomach, which are a little different from the anatomical division. So we have the cardiac region here. It has cardiac glands. They're really not exciting at all. They secrete mucus though, but that's about it. The biggest region of the stomach is the fundic region, aka accentic region of the stomach. It includes the anatomical fundus and body of the stomach. Then we have the pyloric region, which includes excuse me, the pyloric region and the pyloric canal here. Pyloric antrum, it's sometimes called, but for pathology, it's just the pyloric region here. We talked about stomach glands. They were a little confusing, but there's basically 3. Remember, stomach glands was one word that covers all 3 of these glands: cardiac, fundic, and pyloric glands. And here's a fundic gland we talked about. Remember these there's stem cells. Remember from physiology, there's stem cells here that give rise to everything. Some cells that through mitosis they create everything: parietal cells, neck cells, chief cells, aka zymogen cells. There's D cells in here as well. They also create a lot of what become mucosal cells, or aka foliolar cells. And those are really important because they secrete mucus and make a protective layer called the gastric mucosal barrier. The main enzyme secreting cells are parietal, chief, and mucose cells. And well, mucose cells, they really don't secrete enzymes per se, but they secrete mucus. I could have taken that out and just said main secreting cells. So the gastric mucosal barrier, I'm not going to get crazy into this again. Go to my YouTube video on physiology of the stomach review. But it's super important because, I mean, the pH of the stomach is around 2, and that would burn a hole just about in anything. But we have a very strong barrier that's made mainly of mucus and bicarbonate. The bicarbonate soaks up the hydrogen ion and makes CO2 and water, that classic reaction. So that's really important. People who don't have a gastric mucosal barrier will get ulcers. They'll get holes in their stomach from the acid, or ultimately can get holes in their stomach. And what do the mucus glands secrete? What's the magic? Well, yeah, they secrete mucus and bicarbonate, but what drives them to secrete this? Something called PGE2 is released from the basolateral part of the cell. So this is important. I'm sure you've studied this before, but these are mucose cells in a fundic gland, or any stomach gland has these. Even the cardiac cells, fundic glands, pyloric glands, cardiac glands all have these mucus secretors. And what drives them is the release of something called PGE2, prostaglandin E2. Prostaglandin E2, via autocrine and paracrine function, it stimulates itself. Could have drawn another arrow going back. Well, I can do it right here. So it's autocrine function and its paracrine function, so it goes over and binds to its buddies as well. And what does it cause the mucose cell to do? Secrete bicarbonate ion and secrete mucin. Basically, water follows the mucin and binds to it. Bicarbonate does. We won't get into that though. But we get this really nice barrier right here, and the acid can't get in to damage the cells. There's a hydrogen molecule because it's grabbed right here by bicarbonate to make carbonic acid, which dissociates into, as we know already, CO2 plus water. Right, we know that reaction. It's in the blood. It's common reactions, buffering system. All right, so really important. What else does PGE2 between these autocrine and paracrine functions? Another paracrine function is it goes over and it binds to ECL cells, enterochromaffin-like cells. Enterochromaffin-like cells release histamine, and histamine binds to, let's draw a parietal cell here. There's a parietal cell. It normally binds to histamine and stimulates it to release hydrochloric acid, right? But PGE stops the production. It shuts down ECL cells so you don't get histamine, and that helps slow the acid release. So not only does PGE2 create the gastric mucosal barrier, complete with, I don't know why they don't include bicarbonate in there. The gastric mucosal bicarbonate barrier would be a better name for it. But not only does it protect it that way, it also shuts off the acid in the stomach, or it tries to. I mean, it can't. It's not a super powerful mechanism. All right, so why did I go down that road? We should talk about prostaglandin E2 a little more, and COX-1 and COX-2 and NSAIDs. So in order to release PGE2, you need an enzyme called Cyclooxygenase 1. And that is inside the mucosal cells themselves. And COX-1 will create, we won't get into the details, but it creates, it has substrates it binds to, and it creates prostaglandin E2, which is spit out the basolateral surface of the mucosal cells, and we know what it does from there. There's several different types of COX enzyme. There's COX-1 and COX-2. There's more than that even. But COX-1 and COX-2 are the big ones. COX-1 is ubiquitous throughout the body, and it's the one that is mainly working in mucosal cells. Mucosal cells have COX-2, but it really is dormant. It doesn't work very much. It can come to life, but it's mainly COX-1 that drives the production of PGE2, which shuts down acid and makes the gastric mucosal barrier. What about inflammation and injury in the cyclooxygenases? Both COX-1 and COX-2 are the driving force for stimulating the process of inflammation. So when you have like an inversion sprain here, and you blow out the ankle and damage some of the ligaments, and ligaments are bleeding, you need to clean that dead tissue up. It can't sit there. And cyclooxygenase is a key driver of the inflammation response. So it's important in cleaning up dead tissue. Remember the inflammatory cascade. Oh my God, we need to know a little bit about this, and I'm sure you know this already. But damaged tissue injury right here releases phospholipase A2, which is very important. That will break down the membrane phospholipids of the endothelial cells that service the damaged tissue, and release arachidonic acid. Arachidonic acid is acted on by COX enzyme, different types of COX enzymes we won't worry about, but those create basically PGG2, which is converted into PGH2 is the big player right here. So these are prostaglandins. What does this prostaglandin do? It turns into either PGE2. PGE2 is acted on by COX-1 to make the gastric mucosal barrier. Okay, that's very important. We know PGE2, great. It does other things too. PGE2 via COX-1 and COX-2 can take out pain, and we won't get into the mechanism, but it decreases pain. PGE2 can also be acted on to reduce fever, basically by releasing cytokines. And now back to PGH2, that can increase the inflammatory process via COX-1 and COX-2 again, because we need inflammation to clean up an injury, so that's good. PGH2 can also, via COX-1, this is important, PGH2 can be acted on by COX-1 to create thromboxane, which is a coagulant. So if you're bleeding and you have blood in the injury, you want to coagulate that. You want to stop the damaged tissue from bleeding. This is an important mechanism. Now notice that over here, COX-2 catalyzes a reaction of PGH2 to do just the opposite. It makes prostacyclin, which is an anticoagulant. Okay, so that's important. It's kind of the yin and the yang here with coagulation and anticoagulation. Okay, we won't worry about the LOX and leukotriene pathway. You'll need that for boards. You'll get that in physiology if you haven't had it. So great, COX enzymes are great. What's the problem? The problem is they hang around too long. And that's the problem. Once the inflammation is cleaned up, the COX enzymes need to shut down, but they don't. They're notorious for being around too long and causing prolonged inflammation. And prolonged inflammation can actually damage good tissue. So it can not only clean up the bad tissue, but it starts ripping up the good tissue. And COX-1 and COX-2 have slightly different jobs, as we said. I just went over everything there, but let's look at COX-1 and COX-2 inhibitors and anti-inflammatories. So NSAIDs, non-steroidal anti-inflammatories, they are their target is the COX-1 enzyme, right? So not so much the COX-2 enzyme. So NSAIDs, the two most common by far are ibuprofen, sodium naproxen, which used to be prescription, and are now, well, they've been over the counter for a long time, but they used to be back in the 80s and such. They were prescription only. So now we can get those for free. And the key with those two, the key with COX-1, or well, if the NSAID's target is COX-1 enzyme, let's go back to our chart, and what does that do? Well, it blocks the step right here. PGE2 is going to be blocked from making the glucose or the gastromucosal barrier. So PGE2 is not going to be able to function to make that barrier, and that's not good because without that barrier, you're going to get acid. It also, reduces the pain response. So COX-1 is responsible for pain. So if you block COX-1, you're not going to get pain. If you block COX-1, your fever is going to decrease. This one doesn't work. Inflammation. You're going to block inflammation, the production of inflammation a little bit with COX-1, but COX-2 is working on the same pathway, so you're going to still have inflammatory products. This is the important one too. So COX-1, if you block it here, thromboxane is not going to be created, so your blood is going to be not so apt to clot. So you'll be more of a bleeder with this intact or with this system going on. Right, now what about COX-2? These are really a good enzyme. These work great for me, although they do upset my stomach after long-term use. But the only one left is Celebrex. Used to be Vioxx, but that was pulled because of blood clots and heart disease, and we'll see why that happened here in a second. But COX-2 has nothing to do with PGE2 with regard to the gastric mucosal barrier, right? So if you take a COX-2 inhibitor, it's not going to inhibit this step. PGE2 is still going to increase the gastric mucosal barrier. It won't be blocked. It'll still reduce pain because it blocks pain. It'll still reduce fever. It'll still reduce inflammation, which is great. It's not going to have any, here's the problem with COX-2. It's not going to block coagulation, but the yin and the yang is messed up. It is going to block the anticoagulation molecules, prostacyclin. And so with this blocked, you're going to have too much coagulation. And if that happens in the coronary arteries or in the cerebral arteries, you're going to get a heart attack or stroke, respectively. See how that works? Okay. I'm sure you've had that before, so expect some questions on that. How do they work? Kind of just told you how they work, but how do they get absorbed? They're absorbed in the small intestine. They are acidic, and you should never take these on an empty stomach because they will go right through the gastric mucosal barrier and damage and cause inflammation of the stomach, of the stomach wall. So always take them with food. They're absorbed in the small intestine. They get in the bloodstream, and they find that out of control inflammation and snuff it out. Or they find PGNE2 and snuff out its ability to make the gastric mucosal barrier. Because here's the collateral damage. So the NSAIDs, the COX-1 inhibitors, will knock out COX-1 in the gastric mucosal barrier. And we need COX-1 to make the gastric mucosal barrier, right? By PGNE2's actions. So therefore, if you take COX-1, you lose your gastric mucosal barrier and you get stomach upset. And eventually, you get ulcers. You can get holes in your stomach from it. Right? So decrease PGNE2. I assume you know this, but if you don't, make sure you do. Without PGNE2 coming out the basolateral surface of the mucose cells, you're not going to have bicarbonate. You're not going to have mucus release, and there goes your gastric mucosal barrier. In addition to that, you're not going to be able to turn off the ECL cells, enterochromaffin-like cells. And so your hydrochloric acid is going to be driven too hard. So double whammy, right? No gastric mucosal barrier to protect from hydrogen ion and the oversecretion of hydrogen ion, all because of PGNE2. So that's why NSAIDs are no good. Or that type of COX-1 inhibitors, which is most NSAIDs. Excuse me again. So increase acid, increase pepsin without the gastric mucosa will lead to some common problems. I keep talking about ulcers, peptic ulcer disease is called PUD, but it can also burn the stomach and it can cause the gastropathies, which we'll talk about. It can cause, if you overproduce acid, you can get GERD and Barrett's esophagus and even esophageal cancer. And then you ultimately, inflammation turns into a lesion and you get a hole in the stomach, a peptic ulcer. In fact, here's someone on long-term NSAIDs who came in with blood, throwing up blood. Hematemesis, and yep, it's got a nice ulcer right there. All right. I do like, because this is kind of endocrinology, this is my territory. Now, I do like this area. So I used to teach this and it took a whole lecture and I just can't be repeating physiology. So I do have, if you're shaky on this, go watch this YouTube video right here. I'll do a quick review, but you're supposed to know this already. Here is the, you can just go to YouTube, Dr. Gillard, and any of these words, stomach glands. It'll pull this video right up. And you should know this. I assume you know this. So we already know the three stomach glands again, cardiac, fundic, and pyloric glands. I'm not going to go over that again. They're named by, they come from the histological regions of the stomach. So cardiac glands are in the cardiac region of the stomach. Fundic glands are in the fundic region of the stomach. And pyloric glands are in the pyloric region of the stomach. Here they are, oxyntic gland, aka fundic gland, and we have parietal cells right here. They're the acid secretors. And then we have where's our chief cells? There's our chief cells, or our zymogen cells. Chief is not politically correct these days, so try to call them zymogen cells. I'm not sure how the board's going to handle that. Guess I'll find out. I'm going in July again to write questions and review questions. Yep. So that's the story there. There's some shutter offers too. There's the both secrete somatostatin. We have fundic D cells. We also have pyloric D cells over here. They both shut down acid production. Pyloric glands, really the only star of the show beside the mucose cells. Let's not forget these are all mucose cells here secreting mucus. All these guys. The only really star of the show here is G cells. And they don't secrete anything into the lumen of the stomach, right? G cells are endocrine. They secrete it into the bloodstream. You know that though, right? The main components of the fundic glands. So fundic glands secrete what? Hipster. This is what Google says. This is a hipster, according to Google. But that works nice for this little mnemonic, HIP. Or that's a hip dude. So fundic glands, hipster. Fundic glands secrete hipster H, hydrochloric acid via parietal cells. I, intrinsic factor via parietal cells. P, pepsinogen, which is converted to pepsin via chief cells. I love this. You better print this out, put this on your wall, because there's going to be 3 or 4 questions on this. This is probably take you down close to a whole grade if you don't know this stuff. And that's what that video goes over. So I'm not going to go crazy into this. You should know this. But basically, food, the sight, the smells, food in your stomach all stimulates Meissner's plexus to release mainly acetylcholine. Acetylcholine, let's follow some of these. Acetylcholine binds to G cells in the pyloric antrum. These G cells release gastrin into the bloodstream. Gastrin binds to ECL cells and stimulates it. It's more powerful than PGNE2, which also inhibits that. There's the mucosal cell right there. But yeah, so it stimulates ECL cells to release histamine. Histamine goes to its H2 blocker, binds to that, shuts it down. Right? Gastrin also flat out binds to CCK2 receptors on parietal cells. So double mechanism. It drives acid release. See, parietal cells are releasing acid and intrinsic factor. And then, if that's not enough, ACTH can directly bind itself. So ACTH, directly and indirectly, binds to all 3 receptors. Directly binds to its M3 receptor, and it indirectly stimulates the CCK receptor and the H2 receptor. So gastrin strongly drives the production of acetylcholine and intrinsic factor. There's some other that comes out of my enteric plexus. There's also a gastrin-releasing peptide that comes out. Does the same thing as acetylcholine. It stimulates the release of gastrin. And what else can we say here? What does ACH do? We said it already binds to the parietal cell. So ACTH, acetylcholine, also binds to the acid turner offers, the D cells. So it inhibits, it binds to D cells and turns off the D cell. Because when the D cell's turned on, by really low pH would turn on the D cell, it releases somatostatin, and that will shut down the production of gastrin. But ACTH can override that. Okay, same over here. ACTH can bind to D cells and shut off the release of somatostatin. And somatostatin can directly bind to parietal cells from these D cells here in the fundic region. Okay, did I get everything? What else? We said these D cells are stimulated. These have a snake tongue and they taste the acid of the stomach. And when too many hydrogens are felt, the D cells they wake up and they release somatostatin, which binds to G cells and shuts off the production of gastrin. Without gastrin, a lot of this mechanism is turned down. One note about gastrin, we're going to look at a tumor in a minute, if you have really high levels of gastrin, it can start to wake up these D cells. Gastrin can bind to somatostatin to wake it up, or to bind to D cells, which stimulates it to release somatostatin, which binds to parietal cells to directly shut off acid production. It also, D cell from the fundic region can also secrete somatostatin, which binds to ECL cells and shuts that down as well. And then we also said acetylcholine can bind to mucosal cells, and it causes the release of PGE2 in the basolateral surface, and that causes decreased hydrochloric acid, increased gastric mucosal barrier through mechanisms we've already talked about. All right, so know that stuff. All right, let's get into a disease here, Zollinger-Ellison syndrome, or ZE syndrome. So this is a tumor. The patient has a tumor. It's usually a pancreatic tumor, and it secretes gastrin. And it doesn't have, there's no binding sites on it for somatostatin. You can't turn it off. It just secretes tons of gastrin. Doesn't always have to be in the pancreas. It can be in other regions as well. But yeah, these patients ectopically secrete gastrin. We've seen that word before. That means you're secreting gastrin in a place other than the parietal region or the pyloric region of the stomach. And what if you have too much gastrin? So what? Well, we know gastrin double stimulates the parietal cells to produce acid, right? It has receptors on the parietal cell, so it binds to parietal cells. Well, let's go look at it. Right? Where's gastrin bind? Here's the parietal cell that makes hydrochloric acid. We know gastrin, there's the gastrin, it binds to its CCK receptor and flat out stimulates the production of HCl. And intrinsic factor is not really important. It also can bind to chief cells. We're not going to worry about that. So, what else does gastrin do? We already said what it does. It also swims over and binds to ECL cells, causes it to release histamine. Histamine binds to the H2 receptors, and that double stimulates parietal cells to make hydrochloric acid. Okay, and even if there's super high levels of gastrin, it'll hit D cells and it'll try to shut it off, but the gastrin levels are so high that the somatostatin can't overcome the super high levels of gastrin. They're not made to be that high, so the D cells can be secreting somatostatin, but it doesn't have that much effect, hardly any effect. Alright, so bottom line is people with ZE syndrome get huge oversecretions of hydrochloric acid. What does that mean? What's the word for that? That's called hyperchlorhydria. Hyperchlorhydria, or you could say gastric acid oversecretion. They're not going to say that. They're going to say hyperchlorhydria. Too much acid in the stomach can cause two familiar things. GERD, especially if you have a loose lower esophageal sphincter, and it can burn a hole in your stomach and cause a peptic ulcer. Right? Everything we said already. There's another thing that can occur if you have too much acid dumping out of your stomach into the intestine. That high acid content will irritate the enterocytes to the point a little inflammation starts, so you can get some stomach pain. But more importantly, if the enterocytes are irritated, they'll stop reabsorbing water, and they'll just let the water run right through. It's almost like water in the filtrate is the same as fecal water in your intestine. And without taking that water out, you're going to have really watery stool, so you have diarrhea. What about the histological appearance of the players here that gastrin is involved with? Well, we know gastrin binds to parietal cells, it binds to ECL cells, it also binds to fundic D cells. So all of those tissues on histological examination are going to be hypertrophic. So they're going to be bigger than normal, they're going to be proliferative, so there's going to be too many of them. Practice makes perfect, right? And you get bigger. So histologists can spot this real easily. How about clinically? What kind of symptoms do people with ZE syndrome? Well, if you have too much acid, you're going to have diarrhea, as we just said. So about 75% of people with this condition have diarrhea. You're going to have upset stomach, which is called dyspepsia, from all that acid irritating the stomach lining and irritating the intestinal lining, maybe even the esophagus. You're going to have heartburn, which is from the esophageal irritation. That's not as common, about 44% of patients, but about almost 75% as well. About 71% will get a flat-out hole in their stomach called a peptic ulcer, and that can be dangerous. It can burrow into an artery or hit an artery underneath the stomach, and you could bleed to death, or it can dump stomach contents into the peritoneal cavity, and you can get peritonitis. Another thing all that acid does, so the acidic pH in the intestine will deactivate pancreatic lipase that's been released. Pancreatic lipase does not work well in an acidic environment, and it'll be deactivated in people with ZEs with all that acid dumping into the intestine. If you don't have pancreatic lipase, what are you going to do with all that fat that you eat? Especially if you're a meat eater and have a lot of fat that you eat. Well, you can't digest it. So the stool is going to look real gross. It's going to look fatty. Is a gross picture warning coming up. And this is called steraturia. And it looks like you're basically defecating clay. It looks like clay, kind of. What's the natural history of this disease. It's interesting because it doesn't go on all the time. It seems to go into periods of remission sometimes. When it's going though, you have ulcers, and the ulcers are in weird places because of all that acid. You get ulcers way downstream in the distal duodenum, even the jejunum. Almost always in a normal person, ulcers are in the proximal part of the duodenum or the stomach, but they're much farther downstream in ZE patients. It can also get a concomitant HP, or getting a concomitant, like in addition to in addition to all these symptoms, you can get an HP infection. No way. The acid is so strong that even H. pylori, which has to live in the acid cloud, has a little cloud around it. It loves acid. It's too much even for HP. So HP infections are rare in these patients. I've asked that question, so make sure you know that. What are the classic findings of ZE syndrome? Again, hypergastrinemia, blood work, you can test for gastrin levels. Gastric hypersecretion, or better word is hyperchlorhydria, which means you have too much acid in your stomach. That can be tested via mammometry. And you have peptic ulcers that are refractory to treatment. So you treat them and they keep coming back. And peptic ulcers in weird places, and GERD on top of that. And then the histologist will see the parietal and ECL hyperplasia. How about the endoscopic appearance? We said this already. Hyperplasia. Practice makes perfect. The parietal cells, the fundic D cells, and ECLs are overstimulated, so they look huge under the microscope. They can get so huge that not only can you see them microscopically, you can see them macroscopically. And so having these gigantic rugae is a sign of Zollinger-Ellison syndrome, but there's some good differential diagnosis. Meniere's disease and lymphoma. Lymphoma's they're both scary ones, so they can look like some scary stuff. So here's in the pyloric antrum, where it's supposed to be smooth, you can see these huge, almost rugae in the pyloric antrum here, in a patient with ZE syndrome. How do you treat ZE syndrome? GERD. I mean, the problem was with acid, so you use proton pump inhibitors are the big treatment, and H2 blockers, and diet. Right is wrong. Don't sleep on the right side. That whole stuff we talked about before. And then you got to find the tumor. Use a PET scan or CT or scintigraphy. Find that tumor if you can. Maybe you'll be able to surgically remove it. If it's in the pancreas, and if it's small, that's inoperable. There's nothing you can do about it. Hipster again, and let's not forget that intrinsic factor is also oversecreted in these patients. So what does intrinsic factor do? So we're kind of switching gears and going to get to vitamin B12. Its job is to bind to vitamin B12 in the duodenum, and then escort vitamin B12 down to cobalamin receptors in the distal ileum. We'll get to that, don't you worry. So let's start talking about vitamin B12, and then we'll finish this in part 2. Cobalamin is B12, and you got to know this stuff. I mean, I'm doing a little nutrition, I guess, here in a way, but it's a water-soluble vitamin. There's something really weird about vitamin B12. It's one of the water-soluble vitamins, yet it's stored in the liver. Not getting ahead of my slides, but that's a most important. When I think of vitamin B12, that's the first thing I think. How weird. Because normally only fat-soluble vitamins are stored. Who are the fat-soluble vitamins? Deek. I know a chiropractor named Deek, D-E-A-K. So those are all fat-soluble. Those are all stored. You have to be careful, don't overtake them. Same with B12. But yeah, so their main function is to synthesize DNA molecules during interphase on the way to making things. So vitamin B12 is very important in the process of blood cell synthesis, especially hematopoiesis, like making red blood cells, It's also very important in replacing damaged and worn out myelin around nerves. And you can see where we're going. Vitamin B12 deficiency. Ooh, what if you can't replace the myelin? That's not a good thing. What if you can't make red blood cells? That's not a good thing. So we're going to have anemia and some neuropathy type conditions. Another thing weird about vitamin B12, it's not made in the human body very good. You can't make very much. The bacteria in your gut can make a little bit, but it's not enough to sustain life. It's only made by bacteria and some algae, and you can get it from yeast too. Vegetarians have to be careful with this one, so they have to figure out where to get their B12. I've known several have come through the program, and they tell me they get theirs from yeast. The human, therefore, is almost 100% dependent on dietary vitamin B12. And there's that. Strangely, it can be stored in the liver, and it's weird for a water-soluble vitamin to be stored in the liver. Foods high in vitamin B12, I always ask this question: eggs, liver, shellfish, sardines, all high in B12. It's stored so well in the liver that you can actually live if you cut all your vitamin B12. If you're put on a raft for 2 years, or put on an island and there's no B12, you can live for a couple years on the stored B12 in your liver. Let's see. Yep. Pure vegetarians can get it from yeast and other sources. How does vitamin B12 get into the bloodstream? That's the next question. So usually we stop right here. So let's stop right here. I feel like I'm on a roll though, but I haven't. Let's keep going. Yeah, should we keep going? Let's go for it. I haven't prepped this, but I've done this so many times. Let's see how I do. So how do you get B12 into the bloodstream? Step 1, you got to eat a piece of food or eat some egg that's got B12 in it. B12 doesn't come by itself. It's got to be bound to something. And there are certain proteins that hook up with vitamin B12. We're just going to call them food binding proteins. So you start chewing and chewing up your food. You can't dislodge the B12 from the food binding protein. They're going to be stuck together. So that's one point. The food also in the oral cavity, it stimulates saliva. We know that. But there's also an enzyme that's produced by the salivary glands. And that's a very important one called Haptocorrin. So Haptocorrin, it's got some AKAs, the R protein, the R factor, transcobalamin 1, Haptocorrin. Technically speaking, you shouldn't call it, you should call it holo-haptocorrin, because there is an apohaptocorrin that's secreted in breast milk. So you shouldn't just call it haptocorrin. But nevertheless, most people call it haptocorrin. So when you see haptocorrin, you assume that it is the holo-haptocorrin that we're talking about. All right, so it's secreted from salivary glands when you're chewing up the food or eating the egg that's high in B12. And it mixes in with a bolus of food, all the food smashed up in your mouth, and you swallow it. So it goes down, the haptocorrin goes down with the vitamin B12, which is still bound to the food binding protein. It goes down into the stomach. Where's the picture? Here it is. So here's inside the egg. Here is vitamin B12, and it's bound to a food binding protein. You're chewing it up. You can't break it loose. You secrete haptocorrin. It can't bind to it yet. It wants to. It's going to soon, but it can't do it yet until it gets in the stomach. Why? Food binding protein is holding on to B12 too strongly. All right. Step 2. So now we're in the stomach. So in the stomach, finally vitamin B12 is broken loose from food binding protein. How does that work? Pepsin does that. Pepsin is very important. So, but you can't make pepsin without something, right? Pepsinogen is secreted. So you need that hydrochloric acid to break, to cleave off part of pepsinogen to make pepsin. So once pepsin is around, and that can autocatalysis, we're not going to get into that, but once pepsin is around, it'll break food binding protein. And now vitamin B12 is naked and afraid in the stomach, and it will be destroyed by the acid if it weren't for haptocorrin. You have a gene mutation for haptocorrin, you're going to be in trouble. You'll have pernicious anemia. But as long as haptocorrin is working, B12 binds to haptocorrin, and the two are safe. It will protect haptocorrin will protect B12 from acid, and it'll be pumped out of the stomach. So out of the stomach goes haptocorrin and B12. And remember, intrinsic factor is also released. It's driven just by the same things that drive the release of acid. So it's definitely around. All right, so now we're out of the stomach and we're in the duodenum, or we're in the small intestine. So now we need to get haptocorrin loose. Haptocorrin has done its job. It's protected B12 in the stomach and protected it in first part of the small bowel. But now comes the pancreatic proteases, namely trypsin and chymotrypsin. They break haptocorrin loose from B12, and now B12 is naked and afraid once again in the small intestine. And almost immediately the intrinsic factor comes into play, because intrinsic factor is also secreted into the stomach. It wants to bind to B12 in the stomach, but it can't. Why can't it? Haptocorrin is still bound to it. It just bound to it. It's got to wait till it gets in the. It has to wait till B12 gets dislodged from haptocorrin. And when it does, by the action of the pancreatic proteases, it's right there. Intrinsic factor is right there to grab B12 and say, it says, don't be afraid, B12. I got you. Puts its arm around B12. Let's go find our new home, which is in the distal ileum. Just a fun fact here, the pancreatic proteases, remember how this thing works. So they're brought to life, the proteases are brought to life by the binding to an enzyme called enterokinase or enteropeptidase, which lives on the brush border of the enterocytes. Remember, the enterocytes have this little brush border where a lot of different enzymes live. Remember, a lot of the enzymes aren't released into the intestine. It's kind of a different model than the stomach, where hydrogen chloride and intrinsic factor are released. It's a different story here, but there are some that come from the pancreas, like trypsin and chymotrypsin. And so trypsinogen comes from the pancreas, inactive. It binds to enterokinase, and that turns it into trypsin. Trypsin then can take its own prohormone, trypsinogen, and cleave its tail off to make another trypsin. So it's autocatalysis. It can also grab chymotrypsinogen and cleave its tail off, which makes chymotrypsin. And these are the active protein cutters here. So those guys are super important. So let's back up. Let's review. So haptocorrin was secreted by the salivary glands. In the stomach, the food-binding protein is broken loose by pepsin. And it's naked and afraid, but don't fear, because haptocorrin is here. It grabs vitamin B12. Together, they're taken out into the duodenum. And intrinsic factor is also secreted by fundic cells, but fundic glands, specifically chief cells, can't bind in the stomach, but it's out here in the intestine. Once the haptocorrin and B12 hit the pancreatic proteases, B12 is broken loose again, and intrinsic factor is right there to grab it, hold its hand, and now they're bound together. So now intrinsic factor B12 complex is heading for the distal ileum. Next step, I like that. I remember that cartoon when I was little. I was so excited when Batman came on, and I remember they used to have that kabam. those little things would flash when he hit somebody. Well, we have cobalamin receptors, and intrinsic factor and B12 are looking for these cobalamin receptors, and AKA is cobalamin receptors. Could be either one of these. There's a bunch of AKAs for these, but the two big ones are cobalamin and cobalamin. These are only in the enterocytes of the distal ileum, and these are the only receptors that can bind intrinsic factor B12 complex. So once it binds to a distal ileum enterocyte, the entire B12 intrinsic factor complex is swallowed into the enterocyte. And in fact, once it's in the cytosol, it's pulled into a lysosome, the Death Star of the stomach. It's got peroxidase and all those just free radicals. It destroys everything. But amazingly, the intrinsic factor and the cobalamin receptor are destroyed by the lysosome. But amazingly, the B12 is not touched. And that's just amazing to me. I don't know how, and they don't know how it stays alive. But here's a Death Star if you're a Star Wars fan. All right, so amazingly, vitamin B12 gets released from the lysosome undamaged. Then it gets spit out the basolateral surface of the cell, and it enters the interstitium underneath the enterocytes. And it's scared again. It's naked and afraid, but don't you fear. Another enzyme called transcobalamin 2 will bind to vitamin B12 in the interstitium. And they hook up together, and together they get sucked into the distal capillary, where they end up in the intestinal veins, and then they go to the superior mesenteric vein, and then they go into the liver, into the hepatic portal vein. Remember this, remember your anatomy. The hepatic portal system is what drains most of the organs in the intestines. And so we're down in the distal ileum down here, and you can see there's the small intestinal ileal veins going into the superior mesenteric vein, and then it goes into the hepatic portal vein, and it gets into the liver. Right, so here we go. There's just a cartoon showing intrinsic factor and B12. They hook up to a cobalamin receptor here, cobalamin receptor. The B12 is kicked out into the interstitium, and it hooks up with transcobalamin 2, and now it's off. It's into the liver. Some of it goes through the liver and gets into the bone cells, or into the bone marrow. Some of it gets into the nerves, and it's very important for myelin and sheath repair in the nerves. The bone marrow, it's really important for hematopoiesis. Yep, and then in the liver, it's absorbed, as we said, and can be stored there as well. And yep, hematopoiesis in the bone marrow, and myelin and sheath repair in nerves. So those are some very important actions for it. There is another way for vitamin B12 to get into the bloodstream. It's not very good, but if you megadose vitamin B, take really high levels of it, you can get a little bump in your vitamin B12 levels. This mechanism is less than, at the best, it's 1% of vitamin B12 can get in this way. It's not enough to sustain life, but if you're borderline vitamin B12 deficiency and you megadose vitamin B12, it may prolong the ultimate shots of B12, which are going to be needed to save your life. Enterocyte absorption of B12. Let's see. So we can use the ability of enterocytes to absorb naked vitamin B12. Yeah, just everything I just said. It can be used to treat early cases of pernicious anemia. It's called superdosing vitamin B12. Eventually, you're going to need intramuscular injections, though. All right, so now that's 70 slides. We're almost done. We got part 2 coming up. So probably another 30 slides, and then we'll call it a day. See y'all later. All right, here we go. It is part 2 of the lecture. On Thursday, it's week 4. And yeah, so let's talk about pernicious anemia. We just talked about vitamin B12 and how that's kind of processed and how that gets into our bodies. But what happens if you don't get enough vitamin B12? Then you get something called pernicious anemia, which is a form of megaloblastic anemia. So this is always a confusing area. So pernicious anemia, sometimes it's called type A pernicious anemia, which is great if you see that because A stands for autoimmune. And yeah, it's a classic anemia, which means there's decreased functioning normal red blood cells. And it usually occurs secondary to an autoimmune attack. There are some exceptions to that, and we'll look at those next time. So mainly it occurs secondary to an autoimmune attack that occurs against the parietal cells via type III antibodies, which we'll talk more about in a minute. What's the mechanism? So before the autoimmune attack occurs, there's because you're usually not born with this, they think. They think that some pre-existing inflammation starts, and that inflammation may get into the parietal cell genes and turn on some genes that are normally dormant, and then all of a sudden your body's immune system doesn't recognize them anymore, and it attacks. It thinks they're foreign. So that's one of the possible causes. So this whole autoimmune attack thing might be predated by a neutrophil-heavy inflammation, according to the latest research. So if you have a destroyed fundic gland, or more specifically, a destroyed parietal cell, it doesn't destroy the entire gland, or much of the gland is studded with parietal cells, so you really get inflammation of the entire gland. So that statement is really correct. It destroys the entire fundic gland by an attack against parietal cells. Well, what do parietal cells make? Intrinsic factor and hydrochloric acid we've talked about. So therefore you have a deficiency or even an absence in hydrochloric acid and intrinsic factor. And then right next door are the chief cells, the zymogen cells, and they're hit as well by this inflammation. And there goes your pepsinogen. So basically there goes your hipster, right? Your hydrochloric acid, your intrinsic factor, and your pepsinogen are the biomolecules that are released by oxyntic glands, aka fundic glands. Yeah, so therefore, based on our last lecture, there's no way you can absorb vitamin B12. You can eat as much as you want of it, and it won't work. And yeah, so then you get a anemia, specifically something called megaloblastic anemia, which there's two subtypes of megaloblastic anemia. A vitamin B12 deficiency is the most common type of this megaloblastic anemia, but a folic acid deficiency or vitamin B9 deficiency can do the same thing. What about antibodies with these things? So you can do blood work, and not everybody, some people can have this without having these exact antibodies, which is a little confusing. We'll look at the antibodies here in a minute. But you can test for antibodies against the parietal cells or against intrinsic factor or cobalamin receptors. And even G cells. There's some rare types that can attack G cells. So we can look for these autoantibodies by testing the blood. Let's go through the big, according to Robbins, the big antibodies that you have to know. There's type 1 autoantibody. This is an attack against intrinsic factor itself, right? So intrinsic factor is made, released into the stomach, and the body sees it and attacks it. So this is not an attack against parietal cells or against fundic glands. Got it? So you're not going to have a damaged stomach. Your hydrochloric acid levels will be normal. But without intrinsic factor, you're going to get vitamin B12 deficiency, because we know from the last lecture that you need intrinsic factor coupled with vitamin B12 to be properly absorbed or bind to the cobalamin receptors, or the cobalamin receptors, if you will. Parietal cells and chief cells aren't affected, so therefore pepsinogen, hydrochloric acid will be normal. Watch out for questions like that. Those type of questions are coming. So yeah, so if you can't bind with intrinsic factor, you can't absorb vitamin B12, and you get vitamin B12 deficiency. So about 75% of patients who are diagnosed with megaloblastic anemia actually have these these type 1 antibodies or autoantibodies. Right? Type 2 autoantibodies are the next most common one. They attack specifically the cobalamin receptors on in the distal ileum, on the epithelial cells of the distal ileum. Cobalamin, cobalamin, those are AKAs. And yeah, so if those receptors are inflamed and mutated, the intrinsic factor and B12 complex can't bind and get taken into the cell and put into the bloodstream. So again, about 75% of patients have type 2 antibodies, or patients with pernicious anemia, I should say, have these type 2 autoantibodies. Then we come to the big one. These are type 3. About 90% of the patients have autoantibodies that are type 3 in classification. And these are the ones that attack the parietal cell. If you really want to get specific, they actually attack the proteins on the hydrogen-potassium ATPase pumps. I won't go any deeper than that. There's a specific protein that they attack. But that's good enough. So the board question could say type 3 autoantibodies attack hydrogen-potassium pumps. Maybe it's not that deep of a question, and it just talks about the glands where these hydrogen-potassium pumps end in. So they live in fundic glands or oxentic glands. So that's the question could say that. Or maybe the question says it attacks the cell where these hydrogen-potassium pumps live. So what cell do these hydrogen-potassium pumps live in? Parietal cells. See how that works? Yeah, so if your parietal cells are messed up, you can't make intrinsic factor or hydrochloric acid. And you'll get some collateral damage as well. The inflammation will spill into the chief cells and destroy them, so you can't make pepsin either. What are some clinical findings, some findings that we could see? These patients will come in with a weakness, a fatigue, which is present in all people or not all people, but people with significant anemia will get these findings of weakness and fatigue because they have a general decrease in body perfusion, so they just don't have much energy. They may have dyspepsia as well if it's a type 3 autoantibodies involved, if there's attack against the parietal cells or against the fundic gland or against the hydrogen-potassium pumps, how deep you want to make that question. That'll inflame the stomach as well, so they get stomach upset, which is dyspepsia. If you have a general loss of body perfusion because you don't have enough normal red blood cells, your heart's going to be pumping faster to try to make up the difference. So you'll have tachycardia, probably tachypnea as well, increased breathing. And yeah, you get this weird upper and lower extremity, kind of a paresthesia type pain. It's called a dysesthesia, where some people get pain or tingling in their fingers and toes and hands and forearms and legs and feet. It could be a burning sensation. It just could be a flat-out pain. Everybody experiences dysesthesia. And they may have balance problems as well because, as we will learn, vitamin B is very important for making myelin. And so you could have a demyelination of part of the dorsal part of the spinal cord, and there goes your proprioception. So you have a really wobbly gait, and you're really clumsy, and you can't do fine dexterity with your hands. How about if you stick an endoscope down in the stomach, what are you going to see? Well, if it's a type 3 autoimmune attack against the fundic gland, you're going to see destruction of that fundic gland. Now, if it's a type 1 or type 2 attack, you're not going to have any problems with the stomach. But the most common, remember we said 90%, is these type 3 autoantibodies. So you will have an inflammation of the stomach as well, and that's going to cause tummy pain, which is called dyspepsia. That is also, we'll talk about this in the future as well, something called chronic atrophic gastritis. Atrophic means the stomach is being destroyed, kind of shrinking with respect to functioning fundic glands. So that's another AKA is an autoimmune gastritis. So in addition to these blood findings and blood sequelae, they're going to have stomach problems as well. What about stomach juice findings? Well, if it's a type 3 autoantibody, and if they don't say, you just assume it's a type 3. You just assume it's an attack. Pernicious anemia is attack against the parietal cells. So just assume that unless they get specific. If they say it's a type 1 or type 2, then they won't have stomach juice findings like this. But if it's a type 3 attack, where the parietal cells are destroyed, then you'll have hypochlorhydria or achlorhydria, meaning no hydrochloric acid or low hydrochloric acid. Then your pepsin from collateral damage, you'll have lack of pepsinogen as well. And diminished intrinsic factor as well, because intrinsic factor also comes out of the parietal cell. So basically no more hipster. What about the blood work in pernicious anemia patients? And you're going to have a whole class on this with Dr. Dumontier, so I won't go crazy into this, but it's basically the same findings as with any megaloblastic anemia. You'll have hypergastrinemia. So why will you have hypergastrinemia? Why will gastrin be oversecreted? Well, the G cells, remember, those things are shut down when the acid gets strong enough. When the pH drops low enough, it shuts off the G cells by stimulating D cells to release somatostatin. But yeah, if there's no acid coming out, if it's destruction of parietal cells, you're not going to have acid. Therefore, there's nothing to turn off the G cells, and they run wild, and you have very high levels of gastrin in your blood. You'll have pancytopenia as well, where all of the cellular elements of blood are diminished. Red blood cells is the most common, but white blood cells and platelets will be decreased as well because the bone marrow is messed up. DNA synthesis is messed up specifically. You need vitamin B12 and folate or folic acid to synthesize, to make for erythropoiesis. You need vitamin B12. Specifically, you have to replicate your DNA. Without B12, you can't do that. So the classic finding in the blood work is something called macrocytosis, where you don't have a normal amount of red blood cells. You have blood cells, but they're way too big and they don't work. They don't carry oxygen. That can also be called megalocytosis or macrocythemia, some AKAs for macrocytosis. And it's not a disease in and of itself. It's just a description of your peripheral blood, not your bone marrow blood. It indicates, what does macrocytosis indicate? Either vitamin B12 deficiency or folic acid deficiency, liver disease, albumin or alcoholism, hypothyroidism. Some cancer medications can do this, and some nasty bone marrow cancers can do this as well. Some more blood work findings. So you'll have macroovalocytes. That's kind of the subcategory of macrocytosis. Macroovalocytes means that the blood cells that are present are really big. They're abnormally large and oval shaped. They can be different shapes as well. You could have ankylocytosis, meaning you have some normal red blood cells, you have some gigantic non-functional red blood cells, and some medium size. You have a whole different collection. Unequal sized red blood cells gets the diagnosis of ankylocytosis. Poikilocytosis is regard to the shape. Normally they're kind of oval shaped, right? So you can have some really strange looking shaped blood cells in a blood smear. And then neutrophils and basophils even, and eosinophils, all of them, especially neutrophils, they should have 3 lobes. They have 6, 7, 8, 9, 10 lobes, so they're multilobular granulocytes, you could say, or especially the neutrophils. Here's a normal blood smear. I don't know if you've had this yet or not, but here's a normal red blood cell. They're really weird, right? They're kind of a dead cell, but they're small. Here's a lymphocyte. They're much smaller than a lymphocyte. 2 of them is about the same size as a lymphocyte. Red blood cells are weird, right? They got that paler center here in the middle. And they don't have any nucleus, they don't have any mitochondria, there's no endoplasmic reticulum, they can't replicate, they can't do protein synthesis, so they don't live forever. But they're really good at carrying oxygen. That's what we need them to be. So just a little, I'm sure you've had this probably in junior high, right? But there's a neutrophil. The beans, the bean, B-E-N, the basophil, eosinophil, and neutrophil, they are all granular cells. They have granules that they can release to destroy bugs. They're a very important part of the body's immune system, of the troops that attack bugs. Collectively, they're called the granulocytes because of these granules in here. And yeah, they're the first inflammatory cells to arrive on the scene of an inflammation. Okay, here's a patient, a blood smear with someone with macrocytosis, and specifically they have an inflammatory, they have an autoimmune attack against their parietal cells, and they can't make vitamin B12, or they can't bind vitamin B12. They can't absorb vitamin B12 because there's no intrinsic factor. But you can see, I'm not sure if we see a single normal red blood cell here anywhere. Maybe looking for, maybe this one's kind of normal, but look at all the different sizes. So poikilocytosis would describe this. And they're huge. There's a lymphocyte, and they're as big as the lymphocyte. So there are different sizes. There's a little one. There's a giant one here. So you could say they have anicocytosis or anicocytotic, meaning unequal. See how that works? We can blow up on some neutrophils here. So yeah, the neutrophils are hypersegmented. There should be no more than, where's our picture? Neutrophil, 3 segments. That's normal. These are neutrophils. I don't know how many they have. 3, 4, 5, 6, 7. This one's got a lot. So, yeah. And the eosinophil, what's that supposed to look like? That's supposed to be bilobular, right? So that's trilobular. So they're all of these granulocytes are hypersegmented. It's classic in this condition. What about bone marrow findings? If you are in doubt, you can take a sample of the bone marrow findings. And the erythroblasts, which are the baby precursors of red blood cells, are gigantic as well. So they get a special name called megaloblasts. And they can even end up in the blood. You can get some of these into the blood. But the key finding of megaloblasts, not only are they big, but they're out of proportion. The nuclear to cytoplasmic ratio is off. Therefore, it's said that they have nuclear to cytoplasmic dissociation. How come? Well, because DNA synthesis makes all the components of the nucleus, and including the chromosomes, and does DNA replication. So that's messed up and doesn't occur, so you get a tiny nucleus. But the cytosol uses mainly RNA synthesis to make its components, and uses ribosomes and protein synthesis, and those aren't affected. So it makes it look like you have a giant cytosol and a little tiny nucleus. And that's exactly what a megaloblast looks like. Megaloblastic anemia, again, it's one of the 2 main subcategories. Or I didn't tell you this one yet. Megaloblastic anemia has some categories under it as well. It's under a category called macrocytic anemia. So we have megaloblastic anemia and non-megaloblastic anemia are the subcategories of macrocytic anemia. And we know that megaloblastic anemia, we've just been talking about, it occurs from a vitamin B deficiency, which is by far the most common cause of vitamin B12 deficiency, or a folic acid deficiency, or B9. How do you remember folic acid deficiency is vitamin B9? How many letters does folic acid have? 1, 2, 3, 4, 5, 6, 7, 8, 9. So that gives you the answer, right? B9 is folic acid. Bone marrow hematopoiesis is dysfunctional because you need folic acid and especially B12 for proper DNA synthesis. So you can't make the components of the nucleus. Right? If you check the MCV, the mean corpuscular volume, or the mean cell volume, which is the relationship of red blood cells to plasma, it's greatly elevated. How come? Because the red blood cells are too big and they take up too much volume compared to the watery stuff, the blood water, you could call it, if you will. So that's greatly elevated. You might need to know this for Dr. Dumontier, but not for me. But so we won't worry about that. The beans, we already said those are hyposegmented. I could probably take that out. What about the nerves? What's the story? How does it affect nerves? I used to think it's a DNA synthesis problem in the nerves, but it's looking that that's not true. So right now the leading theory is the nerve damage is caused by a buildup of methylmalonic acid. So normally methylmalonic acid combines with B12 to form coenzyme A, which is super important in maintaining the myelin sheath. So if you don't have vitamin B12 around, you can't get rid of methylmalonic acid because normally it goes into coenzyme A. So you get a buildup of methylmalonic acid. And it's actually, the newer research says you can actually test for methylmalonic acid levels. And it's a very good way with high sensitivity and specificity to make the diagnosis of vitamin B12 deficiency. And the increased methylmalonic acid can be converted into fatty acids. So you basically get a lot of fatty acids in the coverings of these nerves where myelin's supposed to be. And the fatty acid is not a replacement for myelin. And you get all kinds of conduction problems and spontaneous action potential generation. And if they're nociceptive nerves, it can hurt. It can become painful. And some of these neurological findings in pernicious anemia may occur before the anemia even shows up. So these patients may come into your office with this dysesthesia, this weird pain. They've went online and they think it's sciatica, but it's not sciatica because it's in their hands and their feet. And so they present with a dysesthesia or a symmetrical dysesthesia, which is seen in the upper and lower extremities. That's incredibly rare for that to be any type of disc herniation. All right, and we talked about that the melanin that can't be replaced. It needs a B12 to make melanin, and you get a fatty acid invasion in the myelin sheath, and that is no good. This is a slide that I always ask questions on this. You take this with you for the rest of your chiropractic, or if your MD's watching this, or whoever, physical therapist, this slide is for you forever. So what's the differential diagnosis for a dysesthesia, for this weird burning, tingling, numbing pain in the hands and feet? The first thing you think of is multiple sclerosis. That's another demyelinating disease. Widespread chronic pain syndromes with the phenomenon of fibromyalgia and central sensitization, and too much substance P is another one. Small fiber neuropathy and peripheral neuropathy, usually by uncontrolled diabetes or someone who's just old and they've controlled their diabetes and they've had a long battle. I talked to a professor actually over the weekend who has no feeling in his feet, and he battles ulcers, and he's been a type 1 diabetic, and very smart guy, and he's always taken very good care and tried to keep his blood sugar in check, and even you just can't perfectly keep your blood sugar in check, and the sugar destroys the nerves. Lyme's disease is another common one. Bilateral radiculitis, radiculopathy, unusual for that to be happening in the cervical and lumbar spine at the same time. Guillain-Barré syndrome. What's some more neurological findings? Well, if their dorsal cord and dorsolateral cord is involved and demyelinated, they're going to have trouble with proprioception. They'll have trouble with balance. So they get an ataxia. Maybe even some spasticity. Maybe they'll have some upper motor neuron lesion signs. Their Hoffmans and their Babinskis will be positive. The Rombergs, they're going to be dizzy. You can do Romberg's test. And maybe they'll have some dementia or memory loss starting. How about some other causes of megaloblastic anemia? Well, we said B9 deficiency, but there are medications that can cause it. I think we did this before. Any type of disease or cancer that interferes with DNA synthesis can cause this, like HIV. Some of the myelodysplastic disorders like leukemia can also cause megaloblastic anemia. There are some associations we should know. Pernicious anemia, the autoimmune type of pernicious anemia, those patients have a much higher rate of diabetes, type 1 diabetes mellitus, Hashimoto's thyroiditis, which is a hypothyroidism, vitiligo, like this patient has, is an absence of melanin. We'll talk about that in 7th quarter. Type A pernicious anemia, other associations, huge risk for cancer. If you have a chronic inflammation of the stomach, you have a 26-fold increase risk for developing adenocarcinoma. That's not good. Iron deficiency anemia, about 25% of patients with type A pernicious anemia, or the autoimmune type, they get this. They get iron deficiency anemia as well. We don't know the reason behind that. Thyroiditis, we said Hashimoto's already. This atrophic glossitis of the tongue, the patients can develop this red and shiny tongue and lose all the kind of regular contour of the tongue, sometimes called a bald tongue. And that's because some of the proteins in the tongue are very similar to those in parietal cells, so the body gets mixed up and attacks this. There's another one. Yep, and that's it. All right. This is going on YouTube. I've given up on virtual classroom for the rest of this quarter. See you later.